And good afternoon, everyone, and good morning to Nathalie. I think it's early morning for you. Thanks for joining us, Nathalie. Thanks, everyone, for coming along. I'm Len Gray, for those of you whom I don't know. I think I know pretty much everyone, but here I am. I've just spent the last week with my interRAI colleagues in New Zealand and with the folks in the New Zealand government that are operating and supporting the interRAI effort there, which is going gangbusters. I have to say, it's very exciting to watch. And so I'm all enthusiastic about interRAI for the moment, and I continue to be. So it's very good that you've been able to come along and join us today. We could have the next slide, please, Michelle. Before commencing, I and the university would like to acknowledge the traditional owners of the lands on which we meet, and we'd like to pay our respects to their ancestors and descendants who continue cultural and spiritual connections to country. We at UQ recognise their valuable contributions to Australia and global society. If I could have the next slide, please, Michelle. So I'm not going to make anything more than the introduction I've just made, other than to introduce Nathalie. I've known Nathalie for a good period of time now. I met her first when she was doing some, what I think is pretty formative work on developing the interRAI acute care system back in the before 2010 and subsequently, and her work is still really relevant to where that is up to now. She was then a PhD student, so since then she's come an awful long way, having spent time initially helping develop interRAI within Belgium, but then she moved to Switzerland, where she had a management role with the government, and more recently she's taken up a professorial position at the University of Western Switzerland. But why we're interested to hear from Nathalie, apart from the fact that she's always got good things to say, and she does say it well. In Switzerland, there's been a very interesting approach to introducing interRAI systems into the aged care community program. There's also widespread use in long-term residential care, but today we're going to talk about community care, and I thought her thoughts and observations about how she's contributed to that and how it's being done in Switzerland would be of great interest to us here in Australia, where we're confronted with all sorts of challenges about information management in community care in particular. So I thought it would be very interesting to hear what she has to say. So without any further ado, Nathalie, thanks for coming along, and we'll be very interested to hear what you have to say. Thank you.
Thank you, Len, for this very nice introduction. It is a great pleasure and a great honor to share with you some experience we had here in Switzerland. I'm checking, do you guys see my screen? Yes? Okay, fantastic. So yes, it's early morning here. The sun is getting up. It is winter. We had some snow, but for 2 weeks it wasn't snowing, so people at the weekend were a little bit like, we're missing to go skiing. Maybe next week snow will get there again. So I will have a focus today on the home care assessment strategies we used, but I also will talk a little bit broader about what's the landscape in Switzerland and what has been going on in the past and what do we plan in the future, because I always like to share some lessons learned. So of course, a lot of people, they stay in good health at home as long as possible. But some of them, they make a whole trajectory through the healthcare system. And when we talk about community care, it is always embedded within a trajectory, because a lot of the community services, they are fairly connected within hospitals, GPs, intermediate structures, short stays. And every single setting gives excellent care. But where is the weak spot? It is within those transitions. So how could we tailor a participative policy program where all those actors participate, as for the past 7 years before I was working at a local government where we had a program running up. So when we talk about participation, of course, we can only do it with the actors themselves. So we truly, and from the start, we actively involve them in crafting, in thinking, what is going on now, what has been going on in the past, and where do we want to go in the future. And hereby I acknowledge the great teamwork we had with a lot of different local, international, and national partners. So today, I will first give a little bit a helicopter overview. We take some height. What's the health system landscape? Then I'll go deeper in the home care experiences. I'll give a little bit about what we plan in the future, and then what if. So we go from silos towards a broad system of care, and we would like to shift from focus on disease to capacity and functioning. So today in the healthcare system, we collect a lot of data. It's not that we're missing data. We could even say that maybe we use too much data. Or in any way, when we collect data, everyone has his own way of collecting it. And do we really speak the same language? We take individual snapshots. And then it's the patient, sometimes even with an envelope, with paper in an envelope, moving around the healthcare system like, share doctor, here is what has been shared about my home care service. So there is a lot of fragmentation in the information. Data sharing is often snapshotted and it is not showing an evolution over time. And most likely there is also a loss of crucial important information. And on the other hand, some information we have double and the patient repeats the same questions over and over again. So within my local government where I was working, it's 1 out of 26 cantons, we started saying, okay, let's first make a sort of legal basis. Let's make a decree where officially the politicians give the intention that they would like to develop a policy to facilitate continuity and coordination of care. And it had 2 main axes. One was electronic health records and sharing a platform. And the second X was the interRAI toolkits. So we gave the policy program a name, CORAI, it's in French. Maybe you understand some of the words. It's une coordination des soins renforcée grâce à la suite interRAI. So it says, well, let's reinforce the coordination of care using a toolkit with the interRAI family tools. We are so used in getting data in the system, and we are so used now to standardize ICD-9, ICD-10. We can understand it, and maybe what 50 years ago was a little bit weird to have codes. Now we're very, how do you say it, familiar with coding stuff. Also treatments. No problem in starting coding all the treatments until the very least detail. We even go standardizing what's the molecule in a certain medication. No problem with it. But when we say that we want to code and standardize, what is the effect of the disease on the autonomy of the person? What is the effect of the treatment a person had on his autonomy? What is his or her social economic situation? What's the effect on well-being and mood? Well, what are his plans on mobility and activity? Is there an environment that facilitates recovery or that facilitates to stop a decline? How is this person cognitively functioning and planning his or her day? And then, of course, do we code anything about prevention? So that was the main issue about not only wanting to coordinate the care, but also to say, how can we go towards a holistic and salutogenic approach? How can we also focus on capacity, not only on what is going wrong, but where was the person before and where does the person want to go in his functioning and autonomy and social activities in the future? So it was a holistic approach, not only a technical one, how to share the data across the settings. The interRAI suite, I don't know if a lot of the audience know it, so I give a brief overview. It allows not only to code medications and treatments and diseases, but it is standardization of autonomy, functioning, social well-being, psychological and environmental factors. So within or throughout different instruments, there's a core set of items that are identical and that are the same, and that has a potential to have a harmonized language across the care system. So this means that we have different dimensions, and all of them are standardized, and we can use them for multiple populations, or we can follow up one person in a care trajectory. So the interRAI family has many different instruments, going from childcare to palliative care, going from acute care to rehab, and it is streamlined for vulnerable populations. Here in Switzerland today, so I will switch my presentation about the past and today and about a local government and the national situation. Today, 8 years later, as I moved in 8 years ago, we are now having home care and long-term care assessments. They've been doing RAI assessments in home care and long-term care for about 15, 20 years, but they were only doing it on an older version, and they were only doing it or mainly doing it for administrative reasons, to get reimbursement, to have some proof for insurances. But there was not a lot of use of these instruments. I don't know if you see my pointer, I'm gonna activate it. So there was not a lot of use of these instruments for clinical reasons and for communication. So throughout the past decade, we moved to different instruments, an update to the interRAI version of home care. The newest version of LTCF is in the making. We did pilots on the checkup. We have the community mental health instrument, and pilots are running on pediatrics at home. This is a slide that I'm not gonna tell in detail, but it is just to show that it took years, and it always takes years. What we first did was saying, okay, what is already happening in home care, in hospital, in the transfer documents, and in long-term care? And then we saw that there was a lot of focus on resource allocation. And we, within the program, we wanted to focus on the clinical value. The difference between the green and the blue is that every setting had a different level of maturity. Some already knew an older version of a RAI instrument. Some didn't have any, how do you say it, experience before. So when we draft a policy program, there are different rhythms and different, how do you say it, there's different levels of what is going on. And from the start, we also knew we want to create something not locally for one canton. For us, it is important to have alignments with different cantons together, because then we're stronger, also with the national government, and we want to learn from international experiences, and we really want to integrate them from the start. So from the start, we were having local pilots, but from the start, we were also very focused on integrating all different stakeholders for all these other tasks, because we knew that we wanted to craft something for later on. So let's focus on one of those pilots who was in a home care experience. It is one of the pilots of that CORAI program, and it is focused on independent community dwellers. So it were persons that were getting services or care from the public, how do you say it? The public home care service, because there's private and there is public home care services. Public home care services have about 90% of the market, and 10% is private, but the private part is getting bigger over time. And we were focusing on people that are fairly independent living at home. So when I arrived here in Switzerland about 8-9 years ago, they were very proud to say, we are using the older generation RAI home care instruments, and we try to target to have everyone having an assessment. I was like, okay, fantastic. I would like to learn how you do it. They said, yeah, we have some obstacles, because actually not everyone really is so enthusiastic about doing an assessment. You have kind of a lot of patients that refuse an assessment. The assessors, they're persons that only do assessments. They're not care persons, but they're official assessors that only have that as a job. and we see a lot of motivational issues. It costs a lot, and there's a bad acceptance and image of the RAI home care assessment, because people don't see the need or the added value of it. So in a later stage, they said, okay, that's why we decided, let's make a split. We'll do an assessment, or we target an assessment for those who get care services. Those that get care, like medical care, and those clients that only get services like Meals on Wheels or an alarm system. We will not do any assessment for that group. So that's what they tried. But actually it was not so big of a success. If this is the total population, about 70% of the home care agency clients, they get nursing care. 30% gets only services without nursing care, but only about 1/3 of them gets an assessment. So 1/3 of all the home care clients get an assessment, and they were targeting for years to get 100% coverage of the assessment. You could say, yeah, but maybe it's a little bit higher for older persons. Yeah, it's true. It's a little bit higher, the assessment rates, but it's only 40%. So I was sitting with them around the table and saying, okay, could we differentiate? Because your population is very heterogeneous. They're very young, they're very old, they're very care needed and less care needed. Could we do some case finding? Could we stratify and say, for some we'll take a snapshot, and for some we do a deeper assessment? So could we get a risk stratification by an interRAI instrument? And in the second time, could we get a basic quick snapshot for some of them and have like the really big camera, 360 degrees with a lot of pixels and a lot of information, a comprehensive assessment for some other clients? So we tried to do this two-step stratification. But then, of course, who would benefit from a comprehensive geriatric assessment? It's not based on age, because age is not a good, predictive factor. But we also don't have a boule de cristal who will become more dependent in the future. And there's no molecule about frailty that we can measure with a kind of screening test looking at blood, for example. So what we did is we used the interRAI ED screener, emergency department screener. I don't know if some of you have heard about it. It is the assessment urgency algorithm. So it is not an assessment to say who needs to go to the emergency department. It is who is in need for comprehensive assessment. It takes about 2 minutes. It is on a smartphone, or we integrated it into the electronic health record, and it gives a number from 1 to 6. 1 is, for example, a person that doesn't have any problems with daily decision-making and the basics of ADL, scores him or herself as having good, excellent health, and has a stable condition. A 6, for example, would be a person that has a problem with daily decision-making or with the basic ADLs, and the family feels overwhelmed, as an example. But the decision tree diagram has about 10 to 12 items, and it goes fairly quickly. So we looked at different age groups. Here, this is just generally to say, okay, most of the patients or the clients are fairly old, but not only. About 30–35% of all the clients are younger than 65 years old. Here we look at a distribution in a sample of 22,000 clients, and those are the most aged, and we see that it's not age saying that you have the highest score. We find also fairly aged persons with lower scores, and also the opposite is true. When we look at the green and the brown category, we also have adults in all the different categories. So we could say, okay, maybe this is one of the ways we could stratify. When we look at, first I have to tell you that we decided, also based on experiences in Canada and New Zealand, we put the cutoff at 3. So those who have a 4, 5, or a 6, we would do an interRAI home care assessment. Those who have a 1, 2, or a 3, we would take a lighter assessment, which is called the interRAI checkup. It is another instrument that is designed for community dwellers. So we would stratify 4, 5, 6 interRAI home care, comprehensive assessment, 1, 2, and 3, a lighter assessment, interRAI checkup. So when we look at the group who had an assessment with a checkup during the pilot, this is not a surprise that almost all of them are fairly independent and don't have cognitive problems. This is exactly what the first stratification step has defined for us. We selected those who are fairly independent and have good cognition. So when we look deeper, who are those persons? Well, not surprisingly, 2/3 are female and 80% were newly admitted clients. And we can see that they are fairly independent. They have close friends. They don't feel lonely in general. They rate their health in good or excellent, and they participate in activities that they enjoy. Those are persons that usually wouldn't get any assessment. But in the pilot, we did an assessment with a checkup, which is much shorter, this checkup. And what we see is that it reveals needs that were previously unreported. So we could see from the positive sides, that they have good vision and hearing and communication. But we could also look at what are the unreported needs. We see that there's a high prevalence of feeling sad, little interest over the past days, trouble sleeping. I didn't participate in activities that I enjoy. I frequently feel lonely. Some of the things might be very surprising. For example, I need to make financial trade-offs for medication, food, or shelter. 1 out of 11 persons. Well, this is striking. This is Switzerland in a fairly rich region, in a canton where there's a lot of, how do you say it? It is very, sorry, I like the word in English, but it is surprising in Switzerland that 1 out of 11 persons would make a trade-off for medication, food, and shelter, having home care services. 5% eats less than a meal per day. We could say, that's low. On the other hand, it's 1 out of 20 eats less than 1 meal per day. So those are really questions. What are we doing with it? We have assessed it. We can see it on individual level. When we look at a bigger sample, then we really have to ask ourselves, like, how do we reorganize the care and what's the next step? What do we do with this information? For example, there was a program about dental problems. They were very interested to see that about 1 out of 5 has dental issues, which is usually under-recognized within home care services. Another program was focusing on pain. Well, they were very interested to see that 1 out of 2 had pain in the last 3 days. So it has a lot of information, although the instrument, it is much shorter and quicker than the full interRAI home care assessment. Also, when we look at the home and the surroundings, we see that 1 out of 2 has informal care. 1 out of 10 informal caregivers give more than 5 hours informal care in the past 3 days, which is fairly a lot. And 1 out of 10 feels distressed about the situation of his person. So what has happened in the past 6, 7, 8 years? The interRAI instrument is one of the new kids on the block. It is one of the newer instruments. It was still in research and development and validation phase by interRAI. We started to do some pilots with it. And then the big issue was, okay, after these pilots, we have fairly good results and a lot of motivation to implement it on the cantonal level. And this implementation really was part of a political decision within our local government. and we worked together with the local public home care agency to get the interRAI checkup with the interRAI assessment urgency algorithm up and running. But it took a lot of changes, and I would like to talk about those changes because they're important. It really, truly changed the whole assessment procedure. As you remember, I briefly told you that within those home care agencies, they were already using an older version of the RAI home care, and they were trying to push it to go to 100% coverage. And they were using external assessors who would use the RAI home care service, knock on the door, have a home care assessment being done, and then they don't have any care relationship. So we had to change it. We introduced 2 steps, stratification and then the differentiation between assessment urgency algorithm was a stratification, and the differentiation was a checkup and the RAI home care. Another change we made was that the assessment was not being done by external assessors. The assessment was being done in routine visits. And also one of the important things we changed is that some of the assessments were done with people that were not getting any medical care. They were having social services or other services like Meals on Wheels. So we differentiated also who would do the assessment. So it was not only the nurses, we also trained social workers and occupational therapists to be able to do those assessments at home, where at first it was only nurses assessing. Another big, how do you say it, change was screening by reference care professionals, replacing first point of contact by telephone call. So first we had the screening being done by a telephone call, but then it got replaced in the rollout by the reference persons doing the screening at home. We needed to fine tune, of course, every time there is an introduction of a new instrument, we fine tune it to the local context. But also the output, the scales and the caps are fairly different. We had to use specific software and integrate it in the electronic health records. And we had 1,200 health professionals to train. There was a specific training in client dialogue and prevention, because that was really one of the issues. Once that those results came out of the assessment, how do we give the feedback to the client? And the assessors were giving us, were telling us that that was for them a very difficult part. So now we're 5 years later, and it is very, it would be very interesting to know. Well, what we wanted to do is to have timely detection of change, to pick up early decline, and not to wait until there is a heavy care situation before we do an assessment. So it would be very interesting to see now 5, 6, 7 years later, will timely detection change really the care for early decline? We don't have the numbers yet. My main message of this pilot is not to say that an interRAI checkup can totally replace any other assessment and it is quicker and it is better and we should all just go for the light instrument. No, it is really a complementary system. It is for independent community dwelling persons. It is focused on early detection of decline. It does a very good job in looking at underreported needs. It has a holistic approach. There is an option for self-report. Sadly, for insurance reasons, we could not use a self-report for now, but we're looking at it for the future, and it gives an evolution over time. So we could also have one part of the clients that have checkups being done regularly, and once that they move on within their care process, maybe at one point it does it does make sense to do a more comprehensive assessment. But what is really, really necessary is to really adapt the training needs, because it's a different population. They have a care or a service demand, a need, and we're gonna pick up other needs. So what does it mean? Because for them, very often the clients had the first reaction, you're going to bill me more. Or, no, I don't want to go to a nursing home. I'm good at home. I just ask you one or two services. Please, by detecting all that stuff, I don't want to, this can be a trigger that I have to move out of my home. So it has a really different dynamic to say, okay, we saw that socially and functionally, there might be a higher chance that you have falls. Well, we can come along at your home. We can have a brief evaluation of your bathroom and your floors, and we can help you to get you installed better so you can stay longer at home. And that is a different dialogue than just saying, oh, you have this, and this as problems, and we will help you with treatments. It is more about creating an environment so socially and functionally the persons can stay in full autonomy as long as possible at home. So what about the future? How could we use interRAI more in general in the future? Here in Switzerland, I could very proudly and happily tell you that we made huge progress. We started doing the switch from the older generation RAI home care to the interRAI generation. Now all the home care services in the 26 cantons, it is together in collaboration, close collaboration with Spitex, ISD Swiss, that I really like to acknowledge for all the work they do. Together, we translated 12 manuals of the interRAI home care, the interRAI community mental health, and we're exploring interRAI pediatrics, checkup, and also palliative care. And there is a centralized home care data pool. Also for the nursing homes, there is a switch being prepared to go from the older generation interRAI long-term care, from the older generation interRAI nursing home to the newest generation interRAI long-term care in the next years. And there's potentially interest for other settings. And I could say, well, this is good news. It is good news, but I could also put on my glasses and say, well, there's also some improvement that we could do. When we look back at the context, well, Switzerland has very high life expectancy. Surely it's because there's good chocolate, we have fresh air and super beautiful views and mountains. But we are also being very high on the list of costs and expenditures. So yes, there is, when we look at old age care, yes, the care is being good, but what could we improve? Could we be more efficient? Could we focus more on prevention? Could we maybe look more at quality and also put quality in the paradigm? So when we look at decision-making on policy level or on clinical level, what we could do much, much better is have data-informed decision-making. Of course, the core business, and I say in French, cœur de cœur, the heartbeat of using the interRAI assessments should always be the clinical reasons. Using it for care planning, for communication and follow-up on changes, and using the alert scores, etc. Then, if we have good data and if it is used in a good way, then we could look more at quality indicators and a continuity of information. And there is a huge project that will be announced in a couple of weeks about this quality dimension that is supported by the Swiss government. So for the 26 cantons in the nursing homes. And here we will also work participatively with quality indicators inspired by the interRAI system. Another part is a public health dimension. If we really want to make changes, we have to have good data. And then we can use them for planning, for resource allocation, and for policy. So we have different stakeholders. Of course, care receivers, patients, clients, and their health professionals, they're interested in what's going on and how can we use it. We could move a little bit more to data sharing. And we also have a huge improvement to make about can we track and follow up people across the care continuum. Managers and policymakers, they have other interests. They would like to know what are benchmarks. How can we allocate resources? How can we monitor our system? So everyone is interested in data to use them for different reasons. And interRAI has a potential to fulfill one part or many parts of those. Of course, interRAI cannot be the only health data. There are also many other health data that are very interesting, but they can be complementary to all the health data that exist. When we look at Switzerland how it is used today, the interRAI system, in the nursing homes, it is only used for resource allocation. In the home care system, it is used for assessment and care planning, but we could do a much better job on the yellow and the orange parts. There is still a good room for improvement. So it does have the potential to have a minimum of input and use it for different reasons. What we always hear is, okay, but if we use it, we really need an e-health platform. And usually people really block on it, like what's the privacy and what is technically and how we make it interoperable. And of course, those are very legit concerns. But actually, when we look at pilots and implementations, what we kind of forget is the human aspect. It is, what do we observe today in clinical practice? And are we ready to have structured observations and to have multidimensional instruments? Because many health professionals say, my observations, I write them on a post-it, I give them to a colleague, maybe that's enough. Also, the clinical output, their caps, their scales, they have a lot of information in it, but how to use them. And very often trainings and pilots, they focus on this part, how to code, how to enter the data in software, what software to use. And actually, one of the things that I would like to share is a lot of time and energy and sharing of experiences is about the professional part. How does all these things work together? And what's the expertise to analyze the results, to translate it into care planning, to have multiple disciplines trusting the data that has been collected by others, to have a dialogue with the client and the family. What is your life plan? What are your ambitions in life? Where do you want to go with all those information that we have assessed? And also to have a follow-up. So usually the debates and the trainings are focusing on good coding and software issues, where the biggest and the hardest and the most long way to go is on all these other factors, like really how to integrate it in professional workflows. One other part is data. We're getting fairly a lot of data now in Switzerland. Some are good data, some are very, generalizable data. Some others don't have the perfect quality yet. But we need a lot of people that can make sense out of this data and tell stories and to change, to make it, utile, to make it, I'm looking for the word in English, to make it data that we can get into actions. This is an example where we put different data of different countries together, and it was on one aspect. It was about flu shots in nursing homes, very focused on it. And here we could see Switzerland. We have a lot of heterogeneity, and we're not at all the best of the classroom. So when we look back at the first slide where we have high life expectancy, yay, fantastic. If you look at one subject, come here, it is an example for flu vaccination. Policymakers or home care, nursing home managers, public health specialists, what can we do to interpret this, and what can we do to get better care in the future? How can we make an impact? And that is the circle that we can all do about having it for clinical use, having data being analyzed, and then feeding it back to how can we make an impact. This is a slide that I'm gonna go very briefly. It is just to say there's a lot of work related to it. It's about changing clinical decision-making and clinical leadership. It is crafting assessment systems, adapting them to local contexts, really understanding what are the caps and scales about. A lot of training and education and help and support is needed to get the system running. About data, there's also a huge job about privacy issues, open data, benchmarks, and internationally, we can learn a lot from what has happened in other countries, and we can share a lot of experiences. But it needs a community building. And that community building is really strongly needed. And I'm sure that you in your country also have a strong community and that it's getting stronger and stronger. And I would like to encourage you to keep on doing it, because we need different roles. Some are the persons that are clinically crafting stuff. Others are technically programming it into software. Some have new ideas. Some finance the whole thing. Some other are in the help desk role. And all together with different stakeholders, from insurance companies to the clients and their families, from the managers of institutions to scientific researchers, we all work together to have acceptability improving, to guarantee the coherence within the system, and to get, in the end, actionable data that can get us to measurable results. So a lot of good work and effort is being done in Switzerland. But we could also learn some more. And this is one of my last slides to say, we should go more and more, or there's an opportunity to go more and more to data-informed decision-making and evidence-based care. Clinical leadership is extremely important for every health professional. Reinforce interprofessional and prevention. Continuity of care and care trajectories that goes also together with technical issues like interoperability. A lot of focus is needed also on data literacy. Do we understand our data ourselves? What can we do with it? Can nursing home use their own data? Are they dependent on academics, or can they get trainings about how to use their own data for their own purposes? What are incentives for quality improvement? Empowerment of clinicians, but also empowerment of patients. We are in a context that is fairly decentralized. We have 26 cantons. We have 3 official languages, and it's very multicultural on the work floor. A lot of health professionals have their training in other European or international countries. So also the training level, there's a lot of skill mix and grade mix. And this is an invitation for you to think, what does clinical practice need in your context? It might be very different, or some issues might be the same. If you want to hear a little bit more about other countries, this is paper fresh from the press. It was published 2 weeks ago, where 7 countries from New Zealand to France share their experiences. And then what if everything I told this morning or for you this afternoon can look like a huge, huge mountain? Maybe this all sounds so tiring, and you say, well, I'll wait in my wheelchair, in my how do you say it, long chair, and others will do the job, and I will wake up when it's all in place. Or we could all like get on the backpack, take a map, and go together on the road and continue the road together, because it takes a lot of effort, and it takes a lot of stakeholders, and it takes a lot of time. But I hope this is an encouraging message that step by step and with different stakeholders all together, we can move forward and changes are possible. And I kindly thank you for your attention, and I'm very happy to respond to questions.
Thank you, Nathalie. Fantastic. Better than I'd even hoped. So you said a lot of interesting things there, and a lot, like all jurisdictions, there are kind of things you have to deal with, the common themes and idiosyncrasies, but certainly done a lot of good work. So Murray is going to curate the questions, so I'll keep quiet for a minute and hand over to Murray.
Thanks, Len, and thanks, Nathalie, for an excellent talk. Sorry, I got booted out of the meeting halfway through, but managed to get back in. So since there's a relatively small, relatively manageable number in the audience, instead of typing questions in the chat or the Q&A, just say, pick me, or I have a question, or me first, and then I'll unmute you and you can ask the question directly. to Natalie. So we've actually got a question from Anne Livingston from the Aged Care Industry IT Council. So I think she's logged on as Georgie. So I'll allow Georgie to talk.
Thanks, Murray. Can you hear me?
Sure can.
Yes, I'm not Georgie Girls. I'm Anne Livingston, but I guess, Natalie, great presentation, really thought-provoking. I really thank you for taking the opportunity to present this to us, which is really an important time for our country to consider standardising the approach. So I guess I have a comment that all the issues that you detailed about the importance of use of data to inform care and future services for individuals is as critical right now for our country, and I think we can only get there by the standardisation of approach that you've outlined. But I was particularly interested in your comments earlier in the presentation about the move from having specialist assessment agencies coming into what I would envisage was that clinical staff or other appropriately trained staff in services and support in community settings were undertaking that role. So I'm interested, what was the level of resistance of that shift? What did those specialist assessment agencies then do? Was there enough work that they just got on with other parts of that work? But how was that generally received? Because I think that's a clear opportunity for our country to consider. Thank you again for a great presentation.
It's a pleasure. I first would like to make a differentiation about home care services and nursing homes. And I also would like to stress out that there's not one way it is done in entire Switzerland. There's a lot of heterogeneity. So the example I was giving about home care in public home care services here in a local canton, it was not an external agency. They were hired by the same home care agency, but it were persons that were only doing assessments, but never giving care, or not knowing their colleagues giving the care. So they were not external companies coming in, but they were having a role of being only an assessor, doing an assessment, making a nice report of it, and then the job was done. And that was highly unsatisfying for everyone, because every client also have a reference person, and that reference person says, well, but my observations are different. Also for the client, it was not comfortable because someone came in, asked all those questions, and they were trying to get, how do you say it, a relationship of trust, but then that same person never came again in the home. And then the person that come in the home, they're like, well, I already told everything to your colleague, why do I have to repeat it? So when the clinical persons were, how do you say it, highly open towards changing the procedure and having clinical persons within their observations, within their role of being a reference persons doing the assessments. So the clinical persons were really big fans. The managers, for them, it was different because they had to reorganize everything and they had to retrain assessors to have another job. For the nursing homes, it is different because the nursing homes, a lot of them only use the RAI system to get the money. They never use it clinically. And the smaller nursing homes, they don't have the capacity or they don't have the resources to get trained and to get up to date in the training. So they hire external companies to come in, do the assessments, send it to the government just to get the money. But then the same data are never used again for clinical reasons. But I don't say that every nursing home does it like that, but there are some smaller scale nursing homes that choose it that way. Is that responding to your question?
Yes, thank you very much, Natalie. Thank you.
So there currently aren't any questions queued up in the Q&A. So just pop your hand up or put something in the chat if you want to ask a question, and I will seek you out.
I'll ask something if that's all right, Murray. Nathalie, there was RAI HC was there before you had any involvement in Switzerland. What if you had nothing in place in terms of structured assessment? How would you go about beginning the process and evolving it over time? What's the greenfields kind of approach that you think would be best?
That's a very good question. I don't think nothing exists. Everyone has practices, and everyone holds on to their practices, and everyone thinks that their practice and their assessment instruments are the best. And yeah, we also have some other projects running in other settings. And again, they say, but we are already having this information and we are already doing it, and what the instruments we have are better. So it keeps on being hard. Where to start? I don't think there's a recipe that fits all. It is really going to the field, listening to them, understanding what is their workflow, how are they interacting with the clients, with the family, with the other health professionals, what is the time they have, what are their problems, and then trying to see, okay, some of the issues you have organizationally, where can interRAI give a solution for you? But it can be very different. For some of them, the blocking point can be, me as a healthcare provider, I would like to know how is this functioning and social, psychosocial being of this person, and I don't have any vision on it. I would like to have it. But for another person, another health setting, it could be more about, well, I need something that is super quick and that helps me in one eye glance to have a report. So I don't think there's a magic recipe. It is listening, talking, and then crafting with them, and then adding little by little other advantages.
Thanks, Nathalie.
That's why it takes long.
Great. There's just another question that's just popped up. If we could just squeeze that in the time remaining, Nathalie, from Karen. Karen, would you like to introduce yourself?
Yes, sure. My name is Karen Clifton. I'm from QUT on the End of Life Directions in Aged Care project. I was just very interested in when you're looking at that group of older people that didn't necessarily, that people were looking at saying they don't have many difficulties, and then when you looked at some of their items, there were some red flags along the way, and you sort of talked about maybe looking at this later. Is that the plan? Are you going to look at these people sort of 5 years down the track or whatever and see if they were sort of red flags to potential sort of problems later on?
Mm-hmm. Yes, there is a clinical use and the data research use. Clinically, the idea is to have a checkup every year or every 6 months or every time there is a substantial change in functioning. So that is highly encouraged. And the software also provides that we can follow up persons over time, and we can see, oh, cognition has stayed relatively stable, but we see that ADL's dependency has gone up, and also depression has gone up. So it is the intention to really have over time those snapshots and to really follow them clinically. The question I raised was more about research and policy. Like 5, 6, 7 years later, the intention was to say, we're not going to wait till someone is really already having a geriatric profile and already is having a lot of autonomy and cognitive problems before we can do an assessment. Let's do an assessment as early as possible to catch early decline. But then we need good data and a lot of data. Can we look at system level? if we have been able to change anything with the detection of these early declines on a bigger group. So clinically, we're following up. That's already ticked the box, but we don't know what the effect is. Did we really improve something in getting the early decline as soon as possible identified? Did that respond to your question?
Yes, it did. Thank you.
I think we're beyond the hour, and so just it's up to me to thank you, Nathalie. That was a really great talk. It's so wonderful to hear
Great pleasure.
we're up close. You read about these things, but it's much better to hear it from a policymaker or a health professional in the locality, and certainly lots of lessons for us there. And we'll be thinking about some of the things you said over the next little while. So thank you very much, and I'm sure others would want to join me in thanking you. Talk soon. Bye, everyone.
Yeah, and I wish you all great pleasure and efforts in crafting this together. I'm sure you have a very big community that is growing, and I wish you best of luck.
Thanks, Nathalie. Bye, everyone.
Goodbye.
Thanks, everyone. Bye.